Good morning, everyone, and welcome to the GE practical tutorial about tips and tricks for nutritional assessment at the bedside by using indirect calorimetry method. It's my pleasure to introduce you the presenter of the tutorial, Dr. Jörn Grensemann from the University Medical Center of Hamburg in Germany. He's an intensivist and a member of the Commission for the Standardization and Technical Safety of the German Society for Anesthesiology and Intensive Care Medicine. His main research interests are optimizing nutrition in special critically ill patients and airway management in intensive care units. Dr. Grensemann, thanks in advance for your contribution. Please, the stage is yours.
Thank you for the kind introduction, Gianfranco. When we look at intensive care patients and nutrition, their nutrition unfortunately does not look like this, but rather like this. And the slide before, if we were to eat something, then we would pick as much as we would like to pick, but our intensive care patients can't do that. And we have to get it right for them. And it's very important that we do get it right, because if we miss the right amount of nutrition provided, then we increase their mortality. A slight underfeeding may be beneficial, but if we get the amount far too low, then we increase their mortality again. So to start with this session, I would like to ask you, the audience, how do you assess nutritional requirements of critically ill patients? Can we please start the poll? So what is very common today, as suggested by some societies, to just pick 24 or 25 kilograms per kilogram per day, to use other formulas, Harris-Benedict, Fasey, or others. Then estimation from just carbon dioxide release has been suggested, then measurement by indirect calorimetry, and there may be even other methods available. So please vote now. So the intermediate results show that quite often the 24 or 25 kilogram estimation is used. Other formulas are used, and some are using indirect calorimetry. And even other methods are in use. Okay, can we show the results to the audience, please? Okay. Okay, so 38%, we have 24 or 25 kilograms, 13% other formulas, and 25% each indirect calorimetry or other methods that are being used. And I want to show you how other methods like other formulas or 25, 24 kilocalories do perform. And if you look at data from 2019 and look at formulas, and then you see that not even 50% of the time formulas get a sufficient agreement of 85 to 115%. If you look at an even more precise agreement on the right side, then no formula performs better than 20% of the time. So apparently formulas do not really work well. And there are two reasons for that. The first reason is that energy expenditure in critically ill patient changes over time. We have the concept of the ebb and flow phase, and the energy expenditure rises and then decreases again during convalescence. The other reason is that we have different conditions that change energy expenditure. And the effects are unpredictable. Just for example, in obese patients, we may either have an increased lean body mass or we have sarcopenia. So in the first case, the energy expenditure increases, and the second one, it decreases. Or if we look at carcinomas, neoplasia, then we have the same thing, that we may have inflammation leading to an increase of energy expenditure, or we have a progressive reduction of lean body mass leading to a decrease, and we cannot anticipate that. So we need some method of measuring. But what to do? One possibility no one in the audience uses is that we use ventilator-derived carbon dioxide production to assess energy expenditure. And in a proof of concept study, this worked really well with a very, very good agreement to measurements by calorimetry. And this study also assessed different formulas that did not work very well. We have a cloud of points here with very high limits of agreement for the 25 kilocalories estimation. But looking at carbon dioxide release estimation of energy expenditure in a follow-up study published last year, the authors concluded, and I couldn't do this better, so I just copied it. They had to conclude that the bias of this method is significant and precision and accuracy rates are unacceptably low using this method, and that indirect calorimetry remains the gold standard. So this apparently does not work very well. So looking at indirect calorimetry, we not only measure the carbon dioxide release, but also the oxygen uptake, and we get a respiratory quotient, and we get the energy expenditure calculated from this. How does this work? The basics of this are fairly old by now. They're more than 70 years old, but they're still valid today. And the foundation was laid at the beginning of the 1900s, or even before 1900, that respiratory quotients were measured in direct calorimeters for the metabolism of carbohydrates, protein, and fat, and that it was estimated how many kilocalories per liter of consumed oxygen were released. So I just want to do a little bit of math to derive the so-called Weir formula from Dr. Weir, and the total oxygen uptake from the different components of nutrition B1, and the total carbon dioxide release from the formulas I just showed would be this. And the energy expenditure in kilocalories per liter would be this. And if we insert formula 1 and 2 and 1 and 3, we get formulas 4 and 5, which we can insert into each other, getting formula 6. And if we just take this formula, we see that we have the term minus decimal 365 times proteins. And we know that 1 gram of protein metabolism requires nearly 6 liters of oxygen. And this leads to 2 kilocalories per gram of proteins actually being released. So this has to be subtracted in this formula, and if we convert it to a daily release of carbon dioxide and oxygen uptake, we get this protein correction term in grams. So this is not really much. 2 kilocalories being subtracted for every gram of proteins. It doesn't really matter if it's 10 grams, 20 grams, 30 grams. This would be just 20, 40, or 60 kilocalories being subtracted in this last term. So what current calorimeters do, they just assume 13 grams of protein metabolism. So they subtract 26 kilocalories per day. And this is legitimate to do that because there's no point in actually measuring urinary nitrogen release under clinical circumstances. And this simplifies the calculation. And later on, Frayne in '83 could show that this is even valid for the metabolism of critically ill patients down to a molecular level in lactic acidosis and so on. It's still valid, this formula. All indirect calorimeters have some limitations. Conditions leading to a loss of gas apparently hamper the measurements, like air leaks, pneumothorax, chest tubes, then renal replacement therapy, especially hepatic support, liver support therapy with albumin dialysis removes carbon dioxide from the patient by the extracorporeal circuit, and extracorporeal membrane oxygenation obviously removes gases. An inspiratory fraction of oxygen above 60 to 70%, according to the literature, is the limit of calorimetry. The calorimeter of General Electric, the COVX module, is validated to up to 80 or even higher percent. So to show you some validation data of this module against the Delta track that was regarded as gold standard, but is not available anymore. There are no spare parts. We have virtually no bias and very good precision, and compared to a current different calorimeter, we have no bias at all and a very, very, very good precision for this technology. So the advantages of the GE technology are that we have a continuous measurements and we do not need a user calibration, and it just runs along the ventilation of the patient. And in my ward, we introduced a one-page memo how to do it. There's just 3 lines for background, and then how to actually do it with some pictures and what our nutritional targets are according to the German guideline. So all ventilated patients receive calorimetry. If you do not have the respective GE ventilators, you can even use this module in a vital signs monitor. Now, how to do it? First of all, we pick some time where the patient was stable, and we just need 5 minutes for measurements. We have to ensure that the coefficients of variation for CO2 release and oxygen uptake are below 5%, that the respiratory quotient is plausible, and then we can read the energy expenditure. We should do this in 2 different time points during day. So this is a different patient. we look at the coefficients of variation again below 5%, respiratory quotient is okay. And then we see that we have an energy expenditure of just 18 kilocalories per day per kilogram. This was a fairly little lady, and she only required 1100 kilocalories per day. So if we would have used the formula of 24 or 25 kilocalories, then we would have given her 130% of what she actually would have needed and would have increased her mortality approximately by 20%. We pick two different time points per day and ensure again that our measurements are okay, low coefficients of variation, respiratory quotient okay. And now you see here, it's a little bit above 5%. Not very much. To be honest with you, I thought this would be a valid measurement. Probably I should have picked a different point. Maybe here you see that the carbon dioxide release was far more stable than here, and the same is true for oxygen uptake. And we have only 14 kilocalories per day per kilogram. Sorry, I just wanted to go back to this patient here. The first one, I wanted to point out that in this case, this was a patient with sepsis who was in the reconvalescence phase, and he required 31 kilograms per day, so far more than we would have given him when we just would have used the 24 kilocalories formula. So if we have to pick a method, then I would always prefer indirect calorimetry, calculation of nutritional requirements just by carbon dioxide release or maybe oxygen uptake is not as valid as indirect calorimetry. And the least I would do is estimation by formulas. I know if you do not have any other option and just and do not have indirect calorimetry, then you have to do something. But I think the first thing you should do would be to apply to get indirect calorimeters to actually do measurements so you can improve your patient's care. And indirect calorimetry is also endorsed by the European and the US guidelines in critically ill mechanically ventilated patients. Energy expenditure should be determined using indirect calorimetry, and the American guidelines does suggest indirect calorimetry be used to determine energy requirements when available and in the absence of variables that affect the accuracy. So that would be the limitations, like a loss of gas due to extracorporeal membrane oxygenation or chest tube. So to summarize, both over and underfeeding worsens the outcome of our patients, and a calculation or estimation by formulas, for example, is de facto not possible, and measurements of energy expenditure should be done by indirect calorimetry. So if I had to summarize it in just one word, my summary would be measure. Thank you.
Thank you. Thank you very much, Dr. Grensemann. And welcome again to everybody. My name is Marco Lucchetti. I'm the clinical manager for acute care, and I will take care of this Q&A session. We have already one question for you, Dr. Grensemann. And the question is, in my ICU, we have fewer modules than ventilators. So when should we ideally take measurements?
Yeah, that is a good question, because it reflects the clinical reality that not every ventilator is equipped with an indirect calorimeter. So maybe you have to share the modules between different patients. And what I have shown you at the beginning of the presentation is that the energy requirements change over time. So if you admit a patient ventilated, then we do it that during the first 24 hours, our nutritional goal is just to supply a little bit of enteral nutrition to keep the intestinal villi alive. And that we do not try to meet the actual energy requirements of this patient. So we would start with indirect calorimetry measurements after approximately 24 hours, and do that for 1 day. So we have an initial goal during the acute phase, what we aim to target. To be honest, in the acute phase, we only target about 3/4 of the actual requirements. And this is what is currently recommended by the German Nutritional Society, and probably reduces mortality, as on one of my first slides. So if we need the module somewhere else, then we would again take measurements after on the 2nd or 3rd day and on the 4th or 5th day. And afterwards, we would expect, if we could stabilize the patient, that then the energy requirements do not change that much. So we would take another set of measurements maybe after a week, 1.5 weeks. And after that, usually patient or the nutritional requirements remain stable, except the patient suffers a second hit, maybe another sepsis or something else. So you have to look at your patient and see if he's currently stable or not. If he suffers a second hit, then we would reduce nutrition again and take measurements immediately.
Excellent. Thank you for this very, very, very interesting reply and insights into this. One more question. There are ICU where you usually insert Swan-Ganz catheters to measure cardiac output, and so you maybe can calculate nutritional assessment by using the oxygen uptake on consumption. What do you think about this? It's a provocative question. Do we really need indirect calorimetry in those cases?
Yeah, it's basically, from a theoretical point of view, it is possible to obtain an estimation of energy expenditure with a pulmonary artery catheter. There are some limitations to it. First of all, you just measure the oxygen uptake and not the carbon dioxide release. So it's a little bit like the measurements only by carbon dioxide release I've shown you, and the same is true for this method. There are data from the late 80s and 90s that could show at first a very good correlation with indirect calorimetry, but on follow-up studies, this concept didn't work that well. Now, there are some inherent limitations because you you do not get the pulmonary circulation. It's always excluded from the energy expenditure. So I think, well, if you insert pulmonary artery catheters on a regular basis and you do not have indirect calorimeters, it's better than formulas, but still it does not meet the precision and accuracy of indirect calorimetry. So ideally, you would still perform indirect calorimetry on your patients and use your pulmonary artery catheter for your hemodynamic measurements, but not for assessing nutrition.
So your point is essentially the same for the VCO2.
Yeah.
It's maybe acceptable if you don't have indirect calorimetry, but indirect calorimetry remains the gold standard and is strongly suggested to have it.
Yeah, absolutely.
Thank you. Yeah, thank you. I have one question this is my personal question, and I would like to know your opinion about this. Do you think there is one or maybe more specific patient population, patient category that indirect calorimetry is strongly suggested, or even more suggested than in a common patient in the ICU, of course?
Yeah, I've shown the table in one of the first slides that there are several conditions where it's not possible to I say guesstimate the energy expenditure, because there are conflicting pathologies that may underlie this condition. So typically this would be obese patients, then septic patients, because you cannot estimate the magnitude of the inflammation and you cannot estimate the magnitude of increase in energy expenditure. Then the same is true for example, burn patients. We do not have sufficient data for patients maybe in shock, be it septic shock, cardiogenic shock. So pretty much this applies to all critically ill patients. Now the estimation of energy expenditure may be possible for non-critically ill patients, but in the immediate moment where someone is on our ward, he has a condition to some extent that influences his nutritional requirements. So I would always measure these patients.
Okay, so of course there are some categories that strongly require indirect calorimetry, but
yeah, so
we can say that virtually all patients in the ICU would benefit from energy requirement directly from indirect calorimetry.
That's true. So we even have data today that patients where we wouldn't have thought about it, for example, subarachnoid hemorrhage, that even these patients do have an increased energy expenditure. And we still don't precisely know why that is the case. So we presume that it's due to an increased release of endogenous catecholamines. But this may differ from patient to patient, and even may be dependable on the treatment of the aneurysm, if it's coiled or surgically clipped. So we don't have sufficient data to estimate this, and so besides septic patients, obese patients, burn patients are maybe the three degrees you would usually think about, but we know that even other patients have altered energy expenditure. So I would just recommend to measure all patients if possible.
Thank you. I think we are at the top of the hour, so I maybe leave the floor to Gianfranco to close the session. Thank you.
Yes, thanks a lot, Dr. Grensemann, for speaking during for us during the tutorial, and of course, thanks for thanks to all the attendees who participate to the meeting, to the tutorial. So have a good day, everyone, and stay safe.
Thank you. Thank you. Bye-bye, everyone.
Thank you.